Okay, so what I'm going to do, and it follows right along with the syllabus that I provided, is we're going to kind of work our way from really the mouth to the rectum, and we're also going to wrap up by focusing a bit on the microbiota and some recent observations on that topic. Well, this is a pretty depressing slide here. You know, it's sort of like, well, you're born and you start aging, which of course is literally true. But the bottom line is that really all the organ system functions decline, whether it's, you know, heart and cardiac output, creatinine clearance in the kidney, drug metabolism in the liver, bone mineral density, immune status, and so on. And of course, a major focus of this workshop here today is, you know, how might we perhaps impact favorably upon some of this depressing slope. So I told you we'd start with some interesting post-lunch topics. And as far as I'm concerned, one of the most important is actually the mouth. And of course, as people age, you'll see, you know, stained and worn teeth. Teeth are much more susceptible to fracture, to loss, periodontal disease, very common. See lots of edentulous older adults, and of course as they begin to lose weight, even their dentures often do not fit. And of course we don't have any health care or entitlement program for dental care. But from a nutritional perspective, it's incredibly important. My colleague Dennis Sullivan in Little Rock published the first paper at the top of this slide. Really was a breakthrough paper back in 1993, and they reported that the number of general oral problems was the best predictor of significant involuntary weight loss. And there are other studies that in fact relate these sorts of issues to risk for hospitalization and ultimately even mortality. The second paper here includes an audience member as first author, Reagan Bailey, one of our studies at Penn State from 2004, where again, persistent oral health issues were associated with comorbidity and impaired diet quality in older adults. And of course it makes sense. If you're having trouble chewing, swallowing, mouth pain, you're likely to have compromised nutritional status and a poor quality diet. Well, moving on down the GI tract here, the oropharynx. Some 15% of community-dwelling older persons report swallowing difficulties of some sort. And indeed, the tongue musculature is somewhat decreased. About 40% of older persons complain of dry mouth, and there is indeed some decrease in saliva production, but the biggies would be underlying medical conditions, medications, dehydration. And of course, we prescribe medications all the time that cause horrible dry mouth. There's also a bit of delay in the pharyngeal swallow reflex with decreased peristaltic amplitude and velocity, some impairment in the laryngeal reflex. And the end result is, with aging, some increase in oropharyngeal dysphagia and an aspiration risk. And of course, you know, aspiration pneumonia, especially in skilled nursing facility settings, remains a major source of mortality among older persons. The esophagus, and that's just a cute little manometric study there in the upper right corner that you need not worry about. But the bottom line with the esophagus is really any significant impairment in motility reflects serious underlying disease, things like scleroderma, things like that. More typical with aging would be modest changes in motility impacting upon sphincter pressures, amplitude of contractions, incomplete sphincter relaxation, delayed esophageal emptying, more frequent tertiary contractions, sometimes dilatation, and decreased neurons in the myenteric plexus. But again, the bottom line is if you're going to have significant motility dysfunction in your esophagus, that reflects a pathological problem, underlying disease, or strictures. Reflux disease, or GERD, as we like to call it in medicine, is really quite common. and indeed 25% prevalence among nursing home residents. And interestingly, the severity of reflux esophagitis actually increases with age, but the actual symptoms, the patient complaints, are somewhat diminished. And of course, these days, the mainstay of treatment for GERD are very potent proton pump inhibitors, acid blockers. But these can also be associated potentially with a decline in serum B12 levels. There are some reports of increased incidence of Clostridium difficile colitis, and possibly greater risk of community-acquired pneumonia, and even risk of osteoporosis and hip fracture. Now, in some ways, gastric acid production is part of your host defense mechanisms, in addition to be required for digestion. In terms of overall gastrointestinal motor activity, there is an age-related decline in the number of enteric anticholinergic neurons throughout the gut, and progressive loss of the interstitial cells of Kegel in the stomach and colon. But the reality is it clinically isn't terribly relevant, has surprisingly little impact upon GI motor function unless there is significant underlying comorbid disease. An example would be very advanced diabetes and impaired gastric emptying, altered gastric intestinal motility, things like that. So largely pretty intact. The stomach, gastric acid secretion, basal or stimulated, is actually fairly well preserved in many older persons. On the other hand, a subset of older persons will have achlorhydria associated with atrophic gastritis, and use of NSAIDs, non-steroidal anti-inflammatory drugs, so things like aspirin, of course, are very commonly used in older persons for arthritis pain, other pain, and injury to the stomach, gastritis, inflammation, much more common in older patients using NSAIDs, but this may also have something to do with impaired mucosal defenses in the stomach with aging. And gastric emptying is delayed with mixed or solid meals, but not liquid meals. But again, unless there's underlying disease resulting in gastroparesis, which is a more profound impairment of stomach emptying, you usually don't see much impact. And so a good example of where we'd often see very impaired stomach emptying would be very end-stage diabetes, for example. The liver, pictured there in the upper right corner, does decline in size, secondary to decreased regenerative functions. There is decreased blood flow to the liver with aging, and this does impact upon drug metabolism, the liver being one of your major detoxifying organs. The liver function tests are actually generally pretty well preserved, and you can actually do without a fair amount of your liver and have adequate function to get by. Albumin synthesis is actually modestly decreased, but when you see low albumins in older persons, very low albumins, they typically are going to be reflecting an underlying inflammatory disease or condition. Low albumin is a notoriously poor indicator of nutritional status and a much better indicator of inflammatory status. Not surprisingly, since I said, well, you're born and you start aging, you're born and you start living in an inflammatory state. So at an advanced age, you have greater expression of inflammation-related genes in your liver, which I think is perhaps intuitive. Pancreas also gets a little bit smaller with aging. Its weight declines. You see increased ductal epithelial hyperplasia, narrowing of ducts, lobular fibrosis. And despite decreases in some of the exocrine enzymes, the truth is that most of the exocrine digestive functions remain quite adequate. At least in a rodent model, appears to be some decline with aging in insulin secretion. This does not, however, appear to be a major contributor to diabetes in older persons. Small intestine, that's actually one of my patients in the upper right corner there, or I should say their bowel up there. The structure and absorptive function of the small intestine is fortunately pretty well preserved with aging. And a lot of the absorptive function remains intact. So there's little change in the surface area, crypt depth, villus height, the enterocytes or brush border. And indeed, the brush border enzyme activity for glucose transport is well maintained. There's a little bit of decline in lactase activity, and of course, lactose intolerance is certainly relatively common among older persons, but sucrase, maltase, some of the other enzymes are largely unaffected with aging. The small intestine integrity remains largely intact with normal mannitol absorption, which is a nice way to measure absorptive function in the small bowel. However, because of vascular disease, postprandial, meaning after you eat, hypotension, low blood pressure, is more common in the elderly. And this, of course, when you eat, increases demand for blood flow to your superior mesenteric artery. And if you have compromised blood flow, this can result in hypotension. So it's not that uncommon for frail older people after eating a meal, for example, to stand up and faint, which is obviously puts them at risk for falls. In terms of overall absorption, as I say, by and large, things are pretty well preserved. And of course, some of these things we've already potentially explained, like decreased absorption of B12, especially in achlorhydria or hypochlorhydric states. Lactose, which you have relative lactase deficiency. Calcium, vitamin D, iron, zinc, and magnesium. Little or no change. Protein, fat, carbohydrates, riboflavin, and B6, and increased absorption of vitamin A. Well, I said we'd get to some fun topics for right after lunch, so we might as well get to the backside of things here. Colon and rectum. And actually, that is a CT there of fecal impaction, not something you ever really want to encounter. But of course, in emergency rooms, skilled nursing homes, it's not that unusual to encounter people who haven't had a bowel movement for several weeks. And they can require manual disimpaction, not something you want to sign up for. Anyway, in the colon, you can see, increased collagen, elastic elanin, and oxytolin fibers, decreased neuronal density. And in general, in the colon, transit time is not dramatically impacted with aging. You can see postprandial augmentation of mass movements, segmental contractions of the colon that don't really change too much. The key factors in terms of transit at the large bowel level really would be diet, disease, medications, physical inactivity, all contributing to constipation. And as you might imagine, self-reported constipation increases with aging, is considerably more prevalent as a complaint among women. I suspect it may be that men simply refuse to complain about it. Some 50% of community-dwelling older persons and 70% of nursing home residents experience constipation. And of course, you might imagine laxative use would follow the same trends. Now, there is also a greater frequency of fecal incontinence with aging, on the order of 4% among older persons. But this is most generally associated with significant underlying disease or surgery to be suffering fecal incontinence. The pressure threshold that elicits a sense of rectal filling does increase. There's decreased rectal elasticity, thickening of the internal anal sphincter, impairment of the anal canal resting in maximal squeeze pressures. But bottom line here is constipation is a common complaint. Generally can be addressed. You can see my subtle sense of humor here with the prune up there in the upper right-hand corner. Well, I thought I would wrap up by one of the more intriguing topics, and indeed just the week before I was in Switzerland at really a fascinating microbiota conference. And of course the microbiota are the bacteria that live in your gut, and you have very important relationships with this, and this is just a research field that has exploded. Just a couple of years ago, I chaired an IOM workshop on the microbiota in a field that literally didn't exist, 8 years ago? We had several hundred people show up from all over the world. In fact, the big problem in this field right now is that they're generating so much data from gene sequencing, from metabolomic analyses, that no one knows what to do with all the information. Anyway, your microbiota is relatively stable throughout your adult life unless we screw it up, and we're pretty good at doing that. Changes in diet, gastrointestinal function, and the host immune system can impact upon your flora, and of course doing surgeries, giving people antibiotics, we can foul up your microbiota big time. What you see with aging, however, in general, is an increase in facultative anaerobes and a decrease in beneficial bifidobacteria and other species. There's less microbial diversity in the gut with aging. And potentially greater susceptibility to disease may result. And of course, we're just beginning to learn about these things. So you can see increased risk for gastroenteritis, for Clostridium difficile, colitis, potentially increased risk of translocation of harmful bacteria and their associated endotoxins. And so you'll see a tipping here from this nice review article by Woodmansey with really a fairly precipitous shift over time in the bacterial flora that live in your gut, with increased facultative anaerobes and other species and decrease in the Bacteroides and bifidobacteria. Well, one of the interesting papers that's come out in the last few years, and one of the senior author of this paper was presenting this work actually in Switzerland the week before, so I have some new insights. But basically it appears that the living environment may in fact impact upon your microbiota. And indeed, they systematically looked at community-dwelling older persons versus those in skilled nursing facilities. And found that the community-dwelling older persons had greater numbers of firmicutes and lower proportion of Bacteroides than those residing in long-term residential care. And what was interesting, because they actually found that this sort of co-segregated, the diet co-segregated with the location and the bacterial species, and that the folks that were living in the community setting had lower fat and higher fiber diets, and the folks that were in long-term care had high fat and lower fiber diets, so far from proving causation. They also found that there was much less diversity and less stability of the microbiota among those folks residing in long-term care. And of course, antimicrobial exposure, other drug exposure is very much a part of that. Now, it just doesn't for a moment imply causation, but it's intriguing. It doesn't necessarily suggest that it was their diets, doesn't necessarily suggest it was the environment or the medications. It may be all of the above, all right? But fascinating. And if you look at the metabolome, so these are the metabolic products of the bugs living in your intestine, all right? And stool samples from older persons generally have lower levels of butyrate and increased levels of branched-chain fatty acids, ammonia, and phenols. And reduced fiber intake, which was typical of the older persons, especially in the long-term care setting, was associated with increased fecapentanes, indoles, nitrosamines, and reduced butyrate. And remember, the short-chain fatty acids like butyrate are very important, result from carbohydrate fermentation in your large bowel, and are actually required for sound colon function and health of the colonocytes that line your large bowel. Turns out these are potentially harmful metabolites that you wouldn't necessarily want in your gut, not the short-chain fatty acids, the ones that are described here in older persons, and a very nice citation here if you're interested further in that topic. Well, since we're talking about your microbiota being altered with aging, there'd be a number of potential therapeutic strategies here. They could include prebiotics, which is providing food ingredients that favor the growth of desirable bacteria, for example. Probiotics, which is basically giving people live desirable bacteria. And of course, you go in Europe now, I mean, it's just taken off. You'll see them in vending machines. You can get lactobacillus capsules, for example. People are so intrigued with this. And then symbiotics, which is where you actually get both desirable nutrients for the bugs you want, plus the live bugs. And benefits from using these approaches so far have potentially included antibiotic-associated diarrhea, relapsing Clostridium difficile colitis, and of course everybody's heard about stool transplants, I would assume. Interesting about that is it's actually been around for more than 20 years and only recently is catching on. So people that have Clostridium difficile colitis, which is a major problem in hospitals, skilled nursing facilities, who are failed repeated bouts of antibiotic therapy to treat this, actually respond pretty dramatically to fecal transplant. Traveler's diarrhea studies, foodborne pathogen studies, and even H. pylori-associated gastritis. So it's a growing field, a lot to learn. I found one nice probiotic study in older persons, shown here, an elderly cohort over 65 years of age, where they were supplementing probiotic bifidobacterium, and they were able to measure, one, that there were increased numbers of this bug in the stool samples. There was also increased stool frequency, so constipation was less of an issue, and actually measured reduced inflammatory status. So there may be some potential there. And what about immunosenescence? You know, I started with that awful figure of everything headed on a downward slope. Well, you know, it also applies to, you know, our body defenses. An important thing to recognize is that the gut immune system does impact upon tolerance to ingested nutrients as well as your resident microbiota. You know, you want your immune system to tolerate desirable bugs, right? But you also don't want it to tolerate pathogens. So you really need some rigor there. And indeed, you know, we've talked about how maybe aging living could be a chronic low-grade inflammatory state. And it could well be that the intestine is part of this. And indeed, you know, the epithelial barrier, the innate immune system, the microbiota, they clearly represent a highly complex, multidimensional network that has a critical role in intestinal immune homeostasis. And we are just beginning to scrape the surface of our understanding of this. You know, we honestly have a long, long ways to go. Well, changes with nutrient requirements with aging, I suspect we could stimulate some debate just in the audience we have here about some of this, but potentially increased protein requirements, calcium, vitamin D, folate, B12, decreased requirements for energy, vitamin A, iron in postmenopausal women, makes sense. Well, conclusions. One is a good thing. The aging gastrointestinal tract remains largely intact and functional. That's good news. Most of the dysfunction that we see reflects underlying disease or chronic conditions. Certainly, oral health is a critical nutritional concern, often neglected. Changes in gut function with aging would manifest most commonly as dysphagia, swallowing difficulties, reflux disease or GERD, constipation, or fecal incontinence. And aging-related changes in the microbiota may have important health implications, but we have much to learn in that regard. Two key research priorities here that can come up in the panel discussion, but I thought I would mention them now. First, do the identified changes in the microbiota and their associated metabolome with aging have relevance to human health? And if so, can we favorably intervene upon them to promote improved aging outcomes? Like I say, major hot area for young investigators, for sure. And a much better understanding is needed of the mechanisms that underlie the low-grade smoldering inflammatory state associated with aging. and the possible contributions that the GI tract may have in that regard. Being part of my medical focus, I'm naturally biased that the gut must be the center of everything, but that may not be true. A couple of recent review articles for folks with more interest in this topic. And I'm going to stop right there, and I thank you for your attention.